The critical night always seems to draw a different kind of silence in the ward, a heavier, more profound stillness that hums with hidden anxieties. The blue light from the monitors cast a ghostly pallor over everything, painting familiar faces and unfamiliar shades. My shift started like any other, the rhythmic beep 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 of 100 machines, a constant low thrum in my skull, yet tonight felt different. I walked past room 4, and something in the air, a whisper of neglect, caught my attention. Mr. Davies, the junior doctor on duty, had already written his notes. Stable, minor discomfort, needs observation. But my gut, that old unreliable friend, screamed otherwise. I paused at the doorway, the sterilized air doing little to mask the faint, metallic scent of antiseptic and something else, something cloying, almost like fear. The patient, Mr. Henderson, lay still, almost to still, his face etched with a silent plea that went beyond the physical. He'd arrived earlier, discharged from another trust with a vague diagnosis, dismissed as attention-seeking by the paramedics, his dignity stripped the moment he crossed our threshold. I'd seen it before, this casual dehumanization, the way the system, in its relentless efficiency, could grind a person down to a set of symptoms, then discard them when those symptoms didn't fit a neat category. My own grandmother, God rest her soul, had faced similar indifference in her final years, a memory that still pricked at me, a silent promise I made to myself then. My fingers traced the cool, smooth rail of his bed. His charts, displayed on the glowing screen, showed nothing overtly alarming, a steady pulse, blood pressure within acceptable limits, saturation holding. All the data pointed to stable, just as Davies had noted. But my eyes kept returning to his chest, the subtle, almost imperceptible shallow rise and fall, and the faint, clammy sheen on his forehead. Observation versus intuition. The internal debate was a familiar one, a relentless wrestling match between protocol and that raw, knowing feeling that screamed wrong. Davies was at the nurse's station, animatedly discussing his weekend plans with Nurse Patel, a detached professionalism masking a deeper disinterest. "Eleanor, everything all right in here?" he asked, glancing up, a hint of impatience in his voice. His gaze flitted from Mr. Henderson to the monitor, then back to me, already anticipating my concerns. He was bright, academically sharp, but sometimes he missed the humanity of it all. He saw a case, not a person. "He's stable. I've checked his vitals twice," he reiterated, as if my very presence questioned his competence. "I just have a feeling, Dr. Davies," I said, trying to keep my voice even measured. "His color's not right. He's withdrawn. More than just discomfort, I think," he sighed, pushing his spectacles up his nose. "Eleanor, we've got 3 traumas coming in from the bypass. We can't get bogged down with every hypochondriac who thinks they're dying." The word hypochondriac hung in the air, a cruel, invisible blow. It was a point of rupture. That was the phrase that unlocked my resolve. This wasn't about me or Davies' ego. It was about Mr. Henderson. I walked back into the room, a sudden cold determination solidifying in my chest. I gently took his hand, feeling the surprising coolness against my palm. "Mr. Henderson," I whispered, "can you squeeze my hand for me?" A faint, almost imperceptible twitch of his fingers. He was trying. He was fighting. I knew what I had to do. I marched straight to the senior registrar's office, bypassing Davies entirely, the hum of the machines now a frantic symphony in my ears. The confrontation was sharp, tense. They initially sided with Davies, citing workload, lack of evidence, the standard litany of excuses. But I stood my ground, my voice rising above the quiet professionalism, describing the subtle cues, the humiliation in his eyes, the disconnect between the numbers and the man. I pointed to a specific, rarely seen pattern in his respiratory rate I'd noticed only because I'd stayed and watched, not just glanced. It took every ounce of courage, but the image of my grandmother's weary face, Mr. Henderson's silent plea, it fueled me. They finally conceded, perhaps to silence me as much as anything, and ordered further tests. The results, when they came, confirmed my worst fears and vindicated my stubbornness. A severe, rapidly progressing internal infection missed by the previous hospital, now dangerously close to overwhelming his system. A swift, intense intervention began, and for hours, the room was a blur of frantic activity, beeping alarms, hushed urgent commands. I watched the monitors, seeing the numbers slowly, grudgingly move back from the precipice. As dawn broke, painting the windows with a fragile, hopeful light, Mr. Henderson was out of immediate danger. He was still weak, still recovering, but alive. More than that, he looked at me, truly looked at me, and in his eyes, I saw not just gratitude, but the return of something vital, his dignity. The system had tried to diminish him, to erase his suffering, but tonight, humanity had won. This wasn't just a medical victory. It was a profound testament to the human spirit's resilience and the power of one person's belief in another. It reinforced every fiber of my being, every reason I chose this chaotic, demanding life. It reminded me that sometimes the most critical diagnosis isn't found on a screen, but in the quiet, unwavering conviction of a nurse's heart. I knew then, with absolute certainty, that I would keep fighting every single critical night. That night started like any other, the perpetual hum of the resuscitation bay a dull thrum against the backdrop of distant sirens. But then he arrived, not just another admission, not just another case file, but a man in his late 70s, brought in after a fall, frail, bewildered, his clothes soiled, his dignity already shredded by circumstances beyond his control. I remember the sharp sting of it, watching the triage nurse quickly label him non-urgent because his basic OBs were stable, dismissing the profound distress etched into his eyes. My gut clenched. I knew immediately there was more. The fluorescent glare of the overhead lights seemed to amplify his vulnerability, casting long, stark shadows that made the room feel even colder. He shivered, not just from the draft, but from a deeper internal chill. Doctor Davies, a brilliant mind, no doubt, but often blinded by his own textbook certainty, did a cursory examination. Just a nasty bump, Eleanor. Nothing acute. Get him cleaned up, keep him hydrated, and we'll look at a discharge in the morning. He said it with the casual dismissiveness of someone ticking a box, already moving on to the next adrenaline-fueled trauma in Bay 3. But I couldn't move on. I saw the tremor in the patient's hand, the way his gaze kept darting to the monitor, where the ECG scrolled a slow, steady rhythm, utterly failing to reflect the silent screaming happening inside him. My own memories, flashes of my granddad's last days, fragile and dependent, flickered at the edges of my vision. It wasn't just observation anymore. It was intuition, a fierce, protective instinct that screamed, wrong. This is wrong. I spent the next hour trying to piece it together, listening to his fragmented whispers, watching the subtle shifts in his breathing that no one else seemed to notice. The monitors blinked their lazy, indifferent green, assuring everyone of his stability, yet my internal alarm bells were deafening. I tried again with Davies. Doctor, he's deteriorating. His confusion is worsening. His responses are delayed. It's not just the fall. Davies merely sighed, his eyes fixed on his tablet. Eleanor, we've done the neurological checks. He's had a rough night, naturally. Let's not over-medicalize a simple syncopal episode in an elderly gentleman. His tone was patronizing, a subtle rebuke to my insistence. Other nurses, busy with their own overwhelming caseloads, gave me sympathetic but tired glances. I was alone in this. The point of rupture came when I saw a faint, almost imperceptible blue tinge to his lips. He was cold, clammy, and his eyes, once just bewildered, now held a deep, uncomprehending fear. Despair threatened to engulf me. Was I imagining this? Was I letting my empathy cloud my judgment? No, my training, my experience, my heart demanded otherwise. I bypassed Davies, a move that would undoubtedly earn me a dressing down, and called the registrar on duty, painting a vivid, urgent picture of my observations, detailing the subtle cues that the machines were missing. I practically begged for a more comprehensive blood panel, for a review of his chest x-ray that had been cursorily glanced at earlier. The wait was agonizing, each tick of the clock a hammer blow against my chest. The sterile scent of disinfectant, usually a comfort, now felt like the smell of impending failure. But then, the registrar, younger, perhaps less jaded, returned, his brow furrowed. The repeat x-ray showed a subtle but significant pulmonary infiltrate. His bloods, when they finally came back, confirmed severe sepsis, a silent killer masquerading as simple confusion. The relief that washed over me was so profound it nearly buckled my knees. He was moved to ITU, and for the next few days, I followed his progress relentlessly. Slowly, painstakingly, he recovered. I saw him a week later, sitting up, chatting with the physiotherapist, a faint, genuine smile on his face. His dignity, so cruelly stripped away by circumstance and institutional oversight, had been painstakingly rewoven. He wasn't just a patient anymore. He was a man reclaimed, brought back from the brink of being lost to the system's blind spots. This case, it solidified everything for me. It wasn't just about the medical victory, the correct diagnosis against the odds. It was about the profound human triumph. It was about knowing that every single person who comes through those doors, no matter how broken or bewildered, deserves to have their inherent worth seen and fought for. Dr. Davies might still be dismissive and the system might remain flawed, but my commitment to being that relentless advocate, that unwavering voice against the hum, against the glare, against the quiet injustice, that is stronger than ever. It's not just a job, it's a solemn vow. That night, the air in A&E felt thick and heavy, like something noxious was brewing, and then Mrs. Henderson arrived. She was brought in by paramedics, slumped on the trolley, eyes vacant, breath shallow. Her clothes were soiled, her hair matted. The smell, I won't forget it. Immediately, I saw the flicker of disdain in some eyes, heard the murmurings another social case, probably neglected herself. But I looked into her face, saw the tremor in her hand, the desperate clutch at the sheet, and my gut twisted. This wasn't neglect. This was something else entirely. Dr. Davies, his usual clipped, efficient manner amplified by fatigue, made his assessment. He glanced at the basic vitals, tutted at her low blood pressure, muttered about dehydration and a probable UTI, and then, as if she were an inconvenience, ordered her to a cubicle for fluids. Keep an eye on her, Eleanor, but I think we're looking at a standard admission to the general medical ward, he said, already turning to the next incoming trauma. His focus was on symptoms, on the visible, on ticking boxes. He didn't see the silent plea in Mrs. Henderson's eyes, the profound shame etched across her face. He didn't see her. My own vision, though, was consumed by it. The sterile, unforgiving white lights of the cubicle seemed to magnify her vulnerability. The quiet, rhythmic beep of the saturation monitor, the soft hiss of the oxygen, only underscored her fragility. I administered the fluids, but as the hours crawled by, a cold certainty solidified within me. Her blood pressure remained stubbornly low, her confusion deepened. Davies popped his head in again, gave her a cursory once-over. Still sluggish, is she? Happens with dehydration. She'll perk up. He'd said it with such finality, as if his words could simply force her system into compliance. But the memory of my own Nan, dismissed with a similar brusqueness once, gnawed at me. A deep-seated unease festered. This wasn't just dehydration. It was a pattern, a quiet escalation of symptoms that didn't fit the standard case Davies had so readily assigned. I felt a surge of frustration, that familiar burn in my chest when I saw a patient being reduced to a diagnosis rather than being treated as a complex individual. I pulled up her sparse notes again, scanned for anything, a tiny detail. And there it was, a fleeting mention from the paramedics, almost an afterthought. Complained of vague abdominal pain earlier. I knew Davies would balk. He was already stretched thin, every bed on the ward taken, and he hated being challenged. But as I watched Mrs. Henderson drift in and out of consciousness, her lips parched, her breathing growing more labored despite the oxygen, I knew I couldn't let it go. Doctor, I began, voice firmer than I'd intended, I think we need to look closer. Her abdominal pain, it could be more than just a vague symptom. We're not seeing improvement with fluids. He spun round, annoyance clear on his face, the fluorescent light glinting off his spectacles. Eleanor, we've got critically ill patients out there. We can't go chasing shadows for every elderly patient who feels a bit peaky. This isn't peaky, doctor, I insisted, my voice tight, my own fear for her mounting. This is a woman whose vital signs are worsening, whose dignity has been stripped, and whose complaints are being ignored. I think she needs an urgent abdominal scan. A CT, the words hung in the air, a challenge. Dr. Davies' jaw tightened. For a moment, the silence was deafening, save for the incessant beeping of machines. It felt like a rupture, a decision point. He could dismiss me, or he could listen. His eyes, usually so impassive, flickered. He sighed, a dramatic exhalation, but then, to my surprise, he nodded. Fine, get one organized. But if it's clear, Eleanor, you owe me a late-night coffee. The scan revealed a severe ruptured diverticulitis, a surgical emergency. The relief when the surgeon confirmed it was a physical wave that left me trembling. Mrs. Henderson was rushed to theater. When she emerged, frail but stable, her eyes met mine across the recovery ward. There was no need for words. That quiet gratitude, that faint, almost imperceptible nod spoke volumes. It wasn't just about saving her life. It was about acknowledging her pain, her right to proper care, her inherent worth. It reminded me yet again why I stood here against the current night after night. Her quiet triumph over humiliation, over a system that nearly failed her, wasn't just hers. It was ours. It solidified my commitment to be the one who looks deeper, who listens, who fights. Because sometimes that's the only real medicine. I need a moment to catch my breath during this intense night. Tell me, which city or region in the UK are you watching from right now? Your messages are important. Leave a comment. Now, let's get back to the story. The fluorescent hum of A&E had a way of seeping into your bones, especially on nights like this. It was a relentless, sterile thrum, a backdrop to the chaos and the quiet despair. I remember Mrs. Henderson, not just for her presenting complaint, but for the profound shame etched across her face. She was wheeled in, a woman of evident grace, now reduced to a crumpled heap, her story dismissed before it even began. Just another fall, Eleanor, Dr. Davies had mumbled, barely glancing up from his notes, his voice a dismissive drone. Probably left her in the corridor for a bit. Let's get her cleaned up, then discharge. My gut clenched. It always does, that unwelcome twist when you see the system failing someone who, in their own home, holds a quiet dignity. Her eyes, though, they held something more than just pain. A plea, an unvoiced terror that went deeper than any laceration or bruise. The bright, unforgiving lights of the cubicle seemed to amplify her vulnerability, casting long, stark shadows that made her look even smaller. The blips and chirps from the nearby cardiac monitor, the distant wail of a siren, it all seemed to mock the quiet suffering in her corner. I saw the way her hand trembled, not just from the shock, but from the indignity of having to explain repeatedly that she wasn't just confused. She's clearly distressed, doctor, I'd said, trying to keep my voice even, though my blood was already simmering. Davies, bless his indifferent soul, merely sighed. We're busy, nurse. Let's prioritize. Prioritize. That word always felt like a cudgel used to beat down the quiet, the elderly, the ones who didn't scream the loudest. I knew this feeling, that creeping fear that someone would slip through the cracks, that I might miss something vital. There was a memory, a long-ago whisper of my own grandmother, dismissed by a rushed GP, a memory that still pricked at me. It fueled a stubborn refusal to let it happen again. I stayed with Mrs. Henderson, ignoring the pointed stares from other colleagues, the subtle implication that I was overinvested. Dr. Anya Sharma, usually so sharp, offered a sympathetic but ultimately passive glance, already moving on to the next patient. They were all tired. I knew. We all were, but this wasn't about fatigue. It was about human worth. I checked her observations myself, feeling the clammy coolness of her skin, noting the faint cyanosis around her lips that the hurried initial assessment had conveniently overlooked. The pulse oximeter on her finger glowed a dull red, displaying a saturation that, while not immediately critical, was certainly concerning given her history. This wasn't just a fall. This was something deeper, something insidious. Her breathing is shallower, doctor, I stated to Davies when he finally deigned to pass by again. His eyes fixed on the chaotic whiteboard, barely registered my presence. Probably anxiety, he shrugged. Standard for this age group. That was it, the point of rupture for me. My voice, usually calm and measured in crisis, took on an edge. She's deteriorating. Her blood pressure is dropping and her pain is unmanaged. We need to investigate further now. I felt a tremor of fear myself, a cold dread that I was overstepping. But the image of Mrs. Henderson's quiet terror, the ghost of my grandmother's face, hardened my resolve. He finally looked at me, a flicker of annoyance in his eyes. Eleanor, don't be dramatic. She's stable enough for assessment later. No, she's not, I insisted, my gaze unwavering. We're losing her. The words hung heavy in the air, cutting through the usual din. Suddenly, the pace of the ward seemed to slow, the urgent beeps and distant shouts fading as a cold spotlight settled on our confrontation. It felt like an eternity, that silent battle of wills, before he finally, grudgingly ordered the CT scan. The wait for the results was agonizing. Each minute stretched, taut and thin, filled with the sterile smell of antiseptic and the oppressive silence in Mrs. Henderson's cubicle. I held her hand, watching the numbers on the monitor, willing them to stabilize. Then, the radiologist's call, a pulmonary embolism. Massive, my breath hitched. If we'd waited, if I hadn't pushed. The relief when it came was a wave, almost physical. The subsequent flurry of activity, the anticoagulants, the critical care team, it was all a blur. But what stayed with me, what still resonates, was the look in Mrs. Henderson's eyes a few days later. Not just gratitude, but a profound sense of having been seen. Her dignity, so cruelly stripped away, had been meticulously stitched back together, not just by the successful medical intervention, but by someone who truly believed her. This case, it was a stark reminder of the fragile balance between protocol and humanity. It solidified my conviction that true healing begins not with a diagnosis, but with validation, with the unwavering belief in another person's worth. And I knew with a certainty that hummed deeper than any hospital monitor that this fight, this relentless advocacy, was exactly what I was meant to do. The fluorescent hum of the resuscitation bay usually buzzes with a predictable urgency, but tonight it felt like a silent scream. He lay there, Mr. Henderson, a man reduced to a medical label, syncope, probable dehydration. But I saw the tremor in his hands, not just from weakness, but something deeper, humiliation. It clung to him like the hospital gown, thin and revealing, exposing not just his body but his spirit. My gut clenched. I've seen that look before, too many times. It's the look of someone who feels utterly invisible, stripped of everything. My mind instinctively connected it to the quiet desperation I'd witnessed in my own father's eyes, dismissed and unheard, before his heart truly gave out years ago. That memory always sharpens my focus, turning a vague unease into a burning certainty. It's not just observation. It's a fight. Dr. Davies, bless his perfectly ironed scrubs, was already tapping away at the computer, barely glancing at the monitor displaying Henderson's surprisingly stable, yet misleading, vitals. Another one for the observation ward, Eleanor. Probably just needs a good meal and a cup of tea. His voice was calm, almost bored, a stark contrast to the thrumming anxiety in my own chest. I watched the subtle flicker on the ECG, the tiny, almost imperceptible dip that my intuition screamed wasn't normal for age. I blend what I see with what I feel, a constant internal tug of war between protocol and instinct. Doctor, I began, my voice deliberately measured, his history of recurrent falls, and the way he flinches when we touch his abdomen. There's more going on than simple dehydration. Davies barely looked up. He typed. The sterile white walls seemed to press in, amplifying the coldness. We've done the bloods, Eleanor. All unremarkable. Let's not invent problems where there aren't any. His dismissiveness, the easy way he categorized human suffering, always grated. It was a stark reminder of the bureaucratic wall we often faced. He represented the system's flaw, its tendency to dehumanize. I felt a surge of frustration, hot and sharp, but pushed it down. This wasn't about me. This was about Mr. Henderson. I moved closer to Mr. Henderson, adjusting his pillow, trying to convey reassurance through my touch. We're going to figure this out, Mr. Henderson, I whispered, meeting his eye. They held a profound weariness, a resignation that twisted my stomach. It was in that moment, seeing the deep, bruised purple on his inner arm, not from a cannula, but something else, that the pieces began to click. A fleeting image from a medical journal, a rare condition, a specific type of abdominal pain coupled with unexplained falls. The monitor in the bay seemed to hum louder now, the numbers on the screen dancing, taunting me with their apparent normalcy. But my mind was racing, connecting disparate fragments, forming a picture Davies simply wasn't seeing. His abdomen is exquisitely tender, Dr. Davies, not just generalized discomfort. And look at his purpura, I insisted, pointing to the lesion. Could we just consider a CT of the abdomen, please? The air crackled with unspoken tension. Dr. Henderson, a younger registrar, glanced from me to Davies, a silent conflict playing out in his eyes. He hesitated, then looked away. Davies sighed, a performance of weariness. Eleanor, we have a queue of patients. We can't order advanced imaging on every feeling. That was the point of rupture. My hand instinctively clenched. I felt the familiar burn of injustice. I couldn't let it go. Not this time. My fear wasn't for myself, but for the man whose quiet dignity had been so carelessly discarded. His heart rate just dipped again, I announced, my voice cutting through his protest, pointing to the monitor where the subtle dip had become more pronounced, sustained. And his blood pressure is trending down. He's crashing, doctor. This isn't dehydration. The panic was palpable, not just in my own quickening pulse, but in the sudden alertness of Dr. Henderson. Davies finally looked, truly looked, at the monitor, his expression expression morphing from annoyance to alarm. "Bloody hell," he muttered. The next few minutes were a blur of controlled chaos. Orders barked, instruments prepared, the crash trolley wheeled in. The CT confirmed it, a rare, acute abdominal vasculitis requiring immediate surgical intervention. A condition that could easily be dismissed as humiliation, anxiety, or dehydration. The operating theater door swung shut, and I leaned against the cold corridor wall, heart thudding, the harsh overhead lights blurring my vision. When I saw Mr. Henderson again, 2 days later, he was sitting up, a weak but genuine smile on his face. The indignity had receded. He was no longer just a body on a bed, but a man saved. "You fought for me, didn't you, love?" he rasped, and I felt a warmth spread through me. It wasn't just a medical victory. It was a victory over the dismissive glance, the quick judgment, the system that nearly swallowed him whole. This job, it breaks you sometimes, the sheer weight of what you witness. But then a moment like this comes along, a battle truly won, and it reminds you why you do it. It's about more than medicine. It's about humanity, about seeing the person behind the symptoms and fighting like hell to make sure they're heard. That's what advocacy truly means, and it's a commitment etched deeper into my soul with every single case like Mr. Henderson's. The stark fluorescent glow of A&E had a way of stripping everything bare, illuminating not just the frantic efforts, but the gaping holes in the system, the moments when a person became a case rather than a human being. This particular night, the air thrummed with the usual organized chaos, the steady beep of monitors a relentless counterpoint to the hurried footsteps. But for me, it was the silence from Cubicle 3 that echoed loudest. Mrs. Albright, an elderly woman brought in after a fall, lay huddled, her eyes wide with a fear I recognized instantly, the fear of being unheard. I watched her for a long moment, the pale light of the patient observation screen casting a greenish hue over her face. Her vitals seemed stable, textbook even, yet my gut clenched. It wasn't the numbers that worried me. It was the story in her eyes, a narrative of quiet distress that spoke louder than any alarm. I thought of my own mother years ago, dismissed by an overworked registrar when she knew something was deeply wrong. That memory, sharp and unwelcome, always fueled my fight. I knew this feeling, that internal dilemma of blending cold, hard observation with the almost primal scream of intuition. "Doctor?" Davies, striding past with his customary air of brisk efficiency, paused briefly at the cubicle entrance. "Nurse, just a simple soft tissue injury, likely a bit shaken. Send her home with some paracetamol once the x-rays are back as clear as I expect." He didn't even meet her gaze, his focus already on the next patient, another statistic. His words, delivered with such unwavering certainty, felt like a slap. He saw a fall. I saw a soul crumbling under the weight of indignity, her quiet protest dismissed as anxiety. It wasn't merely indifference. It was a refusal to truly see. But the x-rays, when they finally came, were precisely as Davies predicted, clear. "See," he stated with a dismissive wave of his hand towards the patient. "I told you." The words were like a physical wall, designed to shut down any further discussion. That was the point of rupture for me. The sterile environment, the relentless beeping of nearby cardiac monitors, the low hum of the ventilators, it all seemed to conspire to diminish Mrs. Albright further. I stepped back from the console, my heart thumping, a sudden, cold anger settling deep within me. My colleagues, absorbed in their own urgent tasks, barely noticed the exchange. They saw Davies as competent. I saw him as dangerously complacent. I couldn't let it stand. I rate-checked everything. Her pupils, her reflexes, her blood pressure again. I saw the tremor in her hands, not just from the fall, but from an almost imperceptible shivering. It was the tiny details, the barely there signs, that spoke volumes to my trained eye, screaming that something was fundamentally amiss. A phrase from a forgotten lecture, a rare insidious condition, nudged at the back of my mind. It was a long shot, a needle in a haystack, but the memory of my mother's quiet suffering and Mrs. Albright's silent plea propelled me forward. I pushed for a specific blood test, a rather obscure marker that Davies had never even considered. He argued, of course, citing cost and time, but my resolve was absolute. I presented the evidence, not with aggression, but with an unshakable conviction born of fear for my patient. I wouldn't leave until that order was placed. The tension in that moment was palpable, a silent standoff between system and empathy. Hours later, after a tortuous wait, the results came in. They confirmed my terrifying suspicion. It wasn't just a fall. It was something far more serious, requiring immediate, specialized intervention. The relief that washed over me was dizzying, followed swiftly by a wave of furious satisfaction. Mrs. Albright, who had endured such profound humiliation, was finally seen, finally heard. Her eyes, when I told her, reflected not just gratitude, but a renewed spark of her spirit. She had triumphed, not just medically, but personally, over a system that had nearly rendered her invisible. Watching her wheeled away, finally on the path to recovery, a profound quiet settled over me. This case, raw and emotionally exhausting, had stripped away the layers of routine and exposed the very core of why I do this. It wasn't just about patching up wounds or prescribing medication. It was about protecting dignity, affirming worth, and fighting for those who couldn't fight for themselves. It reinforced, with an almost brutal clarity, that my commitment to patient advocacy isn't just a job. It's a sacred, non-negotiable vow. The echoes of her silent plea and her ultimate victory will resonate within me for a very long time.